außerdem könnte.
Hello again. Welcome back to our next session, which is one of my favorites, laparoscopic surgery in deep infiltrative endometriosis. And next to me is Associate Professor Pawit Sucharit-Pong. He's one of my boss, working here at the Thai-German Multidisciplinary Endoscopic Training Center. So I will let him introduce our speaker, which is Professor Dr. Hans Rudolf Tinneberg, since he's a student of Professor.
Good afternoon, everyone. It is my pleasure to introduce my professor, Professor Dr. Hans Rudolf Tinneberg. He used to be the head of the Department of Obstetrics and Gynecology in Bielefeld, and he moved to Gießen to work as the head of the department for many years when I and Dr. Ampan Tankorakot went there. But now he retired, but he's still working very hard. He had received the Golden Scope Award for Lifetime Achievement in Endoscopic Surgery. He has been a honorary president for the European League of Endometriosis. Right now, he is a chairman of Academy of Medical Chamber in Hessen, Germany. Guten Morgen, Herr Professor.
Guten Morgen.
Guten Morgen.
How are you?
I'm fine. Thank you very much for your kind words. And I'm very happy to see you. And yesterday I could see Ampan and saw Pisut and most of all Professor Pongsak. So it's very nice, but it's not the same as being with you. And I could see that you are not really adhering to Corona rules as we have to do, unfortunately. So you are not only time-wise, you are also Corona-wise ahead of us.
And you are at home or at your office, Professor?
No, this is my home office.
Oh. So it's about 7 o'clock there? Oh, no, 8,
Yeah.
8 o'clock, 7 o'clock?
No, the clock doesn't work, but it's 8 o'clock right now.
8 o'clock, okay.
Good morning from my side. Good afternoon from
my side.
Okay. So you were talking about the deep endometriosis, right?
Yes.
Yeah. It's your time. Thank you, Professor.
Okay. Can I share the screen?
Yes. Okay. Now you're on.
So please let me know whether you can see everything. Can you see all right? And can you hear me?
Yes, loud
Very
and clear.
well.
Wonderful. So my topic is very wide, which is very comfortable. It's surgery in deep infiltrating endometriosis, and this is a topic one could talk about for a very, very long time. But just to also consider what I feel needs to be done first before doing the surgery, that is a proper examination. And there are two things that we feel here in Germany and in other parts of Middle Europe is very important, is that a proper examination is being performed. And first of all, it starts with a speculum examination, and one should have two separate specula in order to also inspect the posterior fornix, because if one has a single speculum, it is just that the cervix will slip into the orifice, and here you can move the posterior speculum, and then you can sometimes see the nodules, or you can even hear the patient saying, "Ouch, this is giving me pain," which is an indicator that there is an infiltration of the posterior fornix and sometimes also the rectovaginal space. Secondly, once this has been done, of course, a rectovaginal exam is important, because only then one can use the middle finger to pass along the rectovaginal space, but also the middle finger, at least mine, even though this is only, I think, 8 centimeters long, can move towards the uterosacral ligaments, but also pass the cervix slightly at the posterior wall of the cervix. So this is very important, and sometimes this is more indicative than many of the imaging procedures. But next to it is a thorough ultrasound examination. And even though you can see this publication is not really one of the newest ones, it's from 2016. It is available in the internet for free. So you can download the idea consensus opinion for free. And this is a very, very good theoretical training for how to do the imaging, mainly using vaginal ultrasound. And you can see here highlighted, the point is that this is a dynamic procedure. And even though some people are not very experienced with it, I strongly advise to use this technique because it should be available in all gynecological institutions, and the combination of speculum, of rectovaginal, and of imaging is very important. And one important aspect too is that one can also see bladder endometriosis, and for that, the bladder should be moderately filled. It should be half full. If the bladder is not full enough, then there is a problem by sort of detecting a nodule in the bladder wall. And if it's too full, then one cannot see properly. The same could be applied to detecting nodules in a better way in the bowel, which would mean that one would have to fill the bowel with water, or also in the vagina. The vagina could be filled with this gel with this contact gel that we use anyway for vaginal ultrasound, but one would have to fill the vagina with it. But then one can see much better than if not doing this. But of course, for the patient and for the entire examination room, it's probably not so nice. And so when following this, we also see that there are soft markers, that there is specific tenderness, and we can also see whether when pushing the ultrasound probe back and forth, we can also see whether certain areas unfold, whether they move, or whether they are fixed, so that we can also use this technique in order to find out whether there is a frozen pelvis. Now, this is one other aspect, and that is when talking about deep infiltrating endometriosis, this is adenomyosis. And a lot of people feel that adenomyosis is very hard to detect, but if you follow the criteria that are detected or that are lined out in this procedure, it is not so difficult, because one very easy thing is the posterior wall and the anterior wall. They could have different thicknesses. And you can see here, this is roughly twice the thickness of the anterior wall towards the posterior wall. So this is an indication for adenomyosis. The other one is like rays of the sun. It is something that you can see here. There's another ray, and there's one ray, and you can also see here these rays. I'm sure everybody has seen these rays and just thought this is an artifact of the vaginal probe or the ultrasound. This is not an artifact. This is sort of like when you do breast ultrasound. If there is a structure in front, then you have this shadow behind. And these shadows come if there are adenomyotic implants here, and they give this sign of these beams. So it is something you need to train, but on the other hand, it is not too difficult to learn. Another aspect is kissing ovaries and endometrioma. Now, this is quite obvious, this homogeneous foggy area here. This is the thick endometriotic fluid, which is inside endometriomas. And this is sort of a spontaneous, immediate diagnosis if you see this, and you can see these ovaries kiss. So quite obvious there are bilateral endometrioma, and this is something that is even by beginners easy to be detected. However, one sometimes has mixed findings like this one, and in those cases, there could be, as we say, lice and fleas. So you can have bad of two areas, and therefore the IOTA criteria should be adhered and started also with respect to detecting this, which means that one checks the size, the structure, and also the perfusion of the underlying areas by ultrasound. So the Doppler should also be used in order to find out whether there are some irregularities so that a malignancy might have to be suspected. The next point is the bladder. So this bladder is not half full, but there is some bladder filling, and we could see that there is the uterus and a massive structure between uterus and bladder. And there is also quite intense perfusion as highlighted by the Doppler ultrasound. And you can see there are more of these ultrasound slides. So this is a tumor that protrudes into the vesical cavity. So this is a massive endometrioma of the bladder. Now, this is the so-called diabolo nodule, a nodule that is between a vagina and rectum and also cervix. And you can see this is here, this is the big nodule that can be detected. And this allows us to classify the tumor. Here you can see it again. So in different areas, and you can see it is a stretch of round about 3 to 4 centimeters. This is here behind, this is the lumen of the rectum, and this is the mucosa, and this is the tumor itself. And particularly when you have performed the rectovaginal exam, because this is not too high, then you can see this tumor, because you know that there is something and you know the right position of the probe. This is another nodule, and it is quite clear. So all these nodules are dark and sometimes even darker. So they are hypoechogenic, not like fluid, but it's like the uterus, or even a little darker. And as you can see here, why is it that it is dark? We have a fibrous area of the tumor, and this is the mucosa. The mucosa very often is not directly affected, and that's why colonoscopies are not effective. Usually it is useless because gastroenterologists very often cannot visualize that there is any damage to the mucosa, even though patients had regular bleedings during their menstruation from the bowel. But behind is the infiltration, and you can see there is fibrous tissue, and the tumor is extending, and of course part had been cut here, so the tumor was much bigger than just this little piece. Now, first of all, one area of bladder endometriosis, and you can see this is not a very spectacular site, no frozen pelvis, nothing. The bowel looks fine, and we have some superficial endometriosis, but what we could also see is that on this area, we could feel it. It was a little hard. So we open the peritoneum, and just in order to be on the safe side, because this is close to the ureter, we perform hydrodissection, and you can see how the fluid does the preparation. So we have a little hole, and we inject fluid in order to get a proper access to this area. Now we are dissecting the vessels. We have opened the broad ligament, and you can see there is there is the uterine vessel, and very close to it also the ureter. You can see this is a bit tricky. And here we can see the ureter and the uterine artery. And even though this patient might still want to conceive, it is no problem to cut the uterine artery, definitely not if it's only on one side. Just to be on the safe side, we do a ligature, and now you can see the ureter is moving, and we now open the bladder because the tumor extends to the bladder. As you can see, we have now opened the bladder, and we will excise this piece of endometrioma. And very important, in order to be able to close the bladder properly, one has to mobilize the bladder. This is one of the ways to ensure that one will not have leakage afterwards or problems. And in this case, we had not performed any previous placement of a double J catheter because we did not expect that the endometriosis had infiltrated this area. And you can see we have the closure. This was a single closure with a Stratafix thread, but there was still a little leakage. So we performed, as you can see, we performed a secondary suture. And I think probably this was also a 3-layer suture, which ensured that in the end, this bladder was fine. But most important is to mobilize the tissue adequately. And this was not a very big excisional defect of the bladder, but it was close to the ureter, and that's why it is a little tricky to do the surgery over here, because there is always, the uterus might always be in your way. I left the little stump of the thread so that I can use it also for making a proper knot and thereby ensuring that the Stratafix cannot get loose. This patient will have a normal bladder catheter for minimum 10 days, probably better 3 weeks. Now, we're talking about the bowel, and that should be the main focus of my presentation. Just a short sort of repetition of the anatomy. As you can see here, this is rectum and sigmoid, but the rectum should be differentiated in rectosigmoid, low rectum, and ultra-low rectum. And of course, this is important as complications are associated with the location. The maximum number of complications are associated with the ultra-low rectum, and that's where we have to focus our attention. And that is also where we have to consider and also explain to the patient beforehand that she might have to undergo a protective ileostoma, just in order to make sure that everything has been done in order to prevent insufficiency of anastomosis. However, the protective ileostoma is not sort of a guarantee for not having an anastomosis insufficiency. Now, there are two different streams of procedures. One is conservative, and that is, first of all, is medical treatment. And medical treatment has been tried in Japan, and perhaps Professor Masaki Ando can comment on this, because Harada from Japan performed quite some tests, but that was that major tumors of patients that refused to undergo surgery were treated with Dianogist. And this group was very careful because they said, we do not know whether this bowel tumor could be malignant, and therefore a biopsy was performed first. And when the biopsy was clearly showing endometriosis, then the medical treatment was performed. However, it could not sort of abolish the endometriosis tumor, but it could decrease the size. And of course, it could in many cases alleviate mainly the pain and the other problems for a couple of years. So if that is something that patients want, it could be an option. However, I must report to you that one patient that had, that I know of, that had, two patients that had a bowel tumor which was classified as endometriosis and where a biopsy was performed after some years showed that there was a small malignancy inside, so which is then a completely different area. This can clearly be explained because endometriosis is always associated with inflammation. That's the main problem. That is what causes pain. That is what causes infertility. And that is what makes also the other side effects like immunology and so on. So this is the problem which cannot be stopped by just pure medical treatment. Next conservative is rectal shaving. And I understand that Professor Pereira from Porto showed some nice slides also using ICG technique, which is very clever in order to find out, did you go too deep and how is the blood perfusion. There are two techniques, the traditional one where you come from the abdominal approach and just shave off the endometriosis, and the other one, the so-called reverse technique, is when you start from the vagina and when you perform this type of surgery from the vagina, which can be clearly done by everybody who is somehow familiar with vaginal surgery. However, and this is what I see every morning, shaving does not mean that you eradicate the tumor, because it is extremely difficult to cut out everything. I mean, this is my personal opinion. And when I shave myself, there's always something remaining. And this is also my feeling or my opinion about shaving in endometriosis. There's always something left behind. And whatever I saw after shaving, not only from myself, but also from other surgeons, after 2-3 years, they might have a recurrence. Now, the radical way is the easiest way and finest way, also mentioned by Pereira, is this resection, and that is a full thickness anterior rectal wall excision, which can be done either with scissors or sutures, but the finest way is with a circular stapler, and there is one way, and I will show this also with a linear stapler if it is only a small implant. Now, the major hard work is with segmental bowel resection, and this can be done with an end-to-side anastomosis or with an end-to-end anastomosis. And if one wants to assure that this is somehow protected, one can also perform an omental flap, and this will also be shown later on. This is just a slide about the shaving, and you can see this is the intention of the shaving, but it has also been clearly shown here. There are small little fingers that might lead into the mucosal area, and once you open the mucosal area, then it is excision. Now here we have a small endometrioma, but you can see if you look at it that it extends roughly about let's say 1 centimeter. And what we do now is very simple. We introduce a rectal probe in order to pass this tumor and to see whether the lumen of the rectosigmoid is not compromised. And then we just take this linear stapler to staple off this tumor. And as you all know, these staplers, meanwhile, because it's a 3-line stapler, they are very safe. And this is something which does not need special attention because the bowel has not been opened, nothing has been done. It is a very clear way of stapling off. And also the meso has not been compromised. Once it has been stapled off, the stapler is being removed, and then the tumor is being extracted through the 12-millimeter trocar, which is needed anyway to perform, to use the staple line. Now, the next way is I'm trying to demonstrate the basic techniques or the systematic way by showing some graphs. These are hand graphs by myself, and that's why they are not perfect. As you can see, this is my attempt to make good graphs. And here you can see that there has been a tumor on top, and the bulk of the tumor has been excised, so that there is only a thin slice remaining on the anterior wall. And the next step is that we perform stitches through this tumor, which allow us to have good access to the tumor and also to approach the aboral and the oral part more, so that we get this tumor more inside the lumen of the bowel. What we then do is we take a grasper and a needle driver and we pull this down into the pelvis, so that this slips into the orifice or into the pouch of the circular stapler. And we usually take a 31 millimeter stapler, but if you have a 33 millimeter stapler, especially for the rectum, this is an easy way. And it is surprising to see how much tissue will fit into this cavity of the circular stapler. This is a very, very nice way, and you can see how it works. This is now the placing the suture, and then the suture is being grasped with a needle driver and another one. And then you can see here, this is the part of the anvil, and this is the circular stapler part. The anvil is now approached to this, and we have to make sure that the Taenia libra is on top. And now all this is approximated, and we can also make sure that the posterior wall is not compromised. And then the disc is excised from the anterior wall of the bowel. Of course, all of you know how a circular stapler works. So this is part of the tissue that we excise, and there is more capacity in here than with these old machines. The next way is that sometimes we have a colpociliotomy, or we even have the uterus being removed. And I might show this slide where we have a large tumor. The size of the tumor is stapled off the rectal or the aboral part, and you could see, since there was an infiltration of the vagina is being opened anyway. And now we pull the bowel out through the vagina, and you can see it is a quite long stretch tumor, and there is now tension on the bowel. We do not want to have tension. The uterus had been suspended, so we let the uterus fall down, and now the procedure continues from below. This is called the nodes technique, the transvaginal route. But this is only possible if the tumor is down below, and I only advise not to open the vagina in order to do so. It is always good to keep the vagina closed. And you can see this is roughly about 10 centimeters of bowel that will be removed. And this lady had sufficiently long rectosigmoid so that it was possible to do this technique. You know this purse string suture clamp because it's the same as used for open surgery for a laparotomy. And if you have the proper gear, then the needle is soft and you can sort of turn the needle in case there is little room to do so. Now the tumor is cut and only the healthy tissue is left behind. Just the way as one would do during a laparotomy. Once we open the purse string suture clamp, we have to use Ellis clamps in order to secure the tissue. And doing this, we can open the oral part of the rectum, and now we close the purse string suture over the anvil of the circular stapler. Once this is done, we then cut. So this is we then perform the circular. This is now a different type. Also with an open vagina, and we introduce, because in this case the tumor is further up, we cut the bowel, typical way, and sometimes, even though it is a 60 millimeter stapler, it is not long enough. And you can see, in order to make life easier, we suspend the ovaries. It's an ovariopexy. And we also cut the superior part, and the tissue is being removed through the vagina. So there are two staple lines with a linear stapler. Here we can see it is not sufficient, even though it was a 60 millimeter stapler. So we have to do a second staple line. Second staple line is fine, but only one staple line is better. If you have more than two staple lines, then the risk of having an insufficiency of the anastomosis later on is increased. There are studies, mainly by bowel surgeons, which clearly show that the more staple lines you have, the riskier this is. So I'm now dissecting the fatty tissue, and this is the second staple line. And now the diseased tissue has been removed between the two staple lines. You can see this is even more than 10 centimeters. This, I think, is roughly 15 centimeters, and it will be removed through the vagina. The cup is the cup of the Mangeshika uterine manipulator. And you can see this has been a very big tumor. This was removed from the top of the bowel first in order to get more mobility of the bowel. And once this has been done, then we approach the anvil and the circular stapler to do this. This is an end-to-side anastomosis, and I will also show you, so it's the same, the Tania Libra on top, how to proceed. Here is the procedure. We have had two staple lines of the linear stapler, and the affected part of the bowel, these 15 centimeters, were removed through the vagina. Then an incision was made parallel to the linear staple line, and the anvil was introduced, and then a purse string suture was handmade around the stump of the anvil, and to finally allow that these two parts are approximated so that this is an end to side anastomosis, even though the proper end to side would be if the incision would have been further up here. But this is in order to decrease the staple lines a little more. Now, we also have another procedure, and that is transanal removing of endometriotic tissue. And this is not the normal speed. This is 1.5 times the normal speed. And you can see when you want to open the bowel, it is not so easy. It takes some efforts in order to really get access to the lumen. And you can clearly see also that there is the mucosa, which is resisting to a certain extent. Now, this tumor is being excised. Mainly, a little piece is left because we have enough space in the circular stapler in order to take this. So now it is introduced. We remove the tissue, and the assistant didn't do exactly what I would like to do, because my preferred procedure is to introduce the anvil and then take the tissue at the same time to remove, because then one only needs to pass the grasper once. Here you can see that the anvil is attached with a pike, so that we can perforate the tissue. And this will be shown right now. By the way, this is an extra anvil grasper. It is a 10 millimeter instrument that allows a proper grip to the anvil. And now we perforate, preferably at the tenia libra, the bowel, and we then allow the anvil to slip into the bowel, as you can see here. Now the anvil is high up, and this is an excellent way of doing it. And then we have two staple lines, one below here and one at the aboral part of the rectum. You might now see some fighting with the instrument. So let's go. So the first staple line, which is the oral part, and this is a longer distance from the stapler, linear stapler, to the anvil. And here is the second part, and this looks a bit remaining disease, so that's why we staple further below. And this tissue here is soft, so that this can easily be removed through a 12 millimeter trocar. But with the disease inside, it is impossible to remove it through the trocar. One would have to slice it. But since the rectum was still open, we can easily remove the tissue through the rectum and even big tumors. So this is the ideal way of midline perforating from the circular stapler. And then you know this already, attachment gives a click noise. Then we have to arrange the Tenia libra in midline, and have to make sure that there is no twisting of the bowel, and then the anastomosis is being fired, and that's fine. Okay. Now, sometimes when the tumor is bigger, we have to do a similar way. We cut off the major bulky part of the tumor, and then we excise the tumor from the bowel and put it aside. We introduce the anvil and remove the tissue, and then we have a stapling line at the oral part. This is placed through the bowel, as you could see, and then the second staple line is being performed, and we then have the click of anastomosing the tumor, just as you saw right there with the video. Now we have an end-to-end anastomosis with only 3 ports. You can see the vagina is open. And this is the rectovaginal space. We have the tumor. And what we now do is we mobilize the bowel from the meso, because we always keep the meso intact. There is no need to also remove the meso, so to go down to the TNM fascia, as the meso has still a function. It is quite well perfused, and it is also a buffer. So we now open the bowel and excise the tumor. And since this is a long stretch area, so if there is too much feces in the bowel, we of course we suck it off and we flush it. And here you can see we remove this entirely. So this is the anal or aboral part, and here is the other part, the superior part. And in this case, we close the oral part because we can remove everything through the vagina. But at the same time, we could also put it in a bag and remove it through this part. You might be concerned of the feces in there, but we never had any problems with feces. We also, meanwhile, we apply pre-operatively a mixture of antibiotics in order to have this extra option. So this is the circular stapler down there. We now have the oral part of the tumor, and we have this long stretch area. As you can see, it's a long area. It's about 20 centimeters. So we have to make sure that we use the tissue carefully. And this long area will be removed through the vagina, and the anvil will be applied, also introduced through the vagina. And now what we do is an end-to-end anastomosis. So we introduce the anvil, and now, since this saves a little space, we perform another hand purse string suture. So that we also ensure the anvil, and now the purse string suture is being closed, and we can Now this is all routine. We can approximate this. If there is too much tissue around here, we can just cut it with a scissor, but just be aware that you do not cut the thread, because then you have to do the suture once again. Now click, the two parts are being joined, and we now have to make sure that the bowel is in the right position, and the approximation of both ends will start. You can see the bowel is quite loose and mobile, which is important, and now it is attached, and these parts are being placed inside the circular stapler so that we get rid of this part of tissue. And you can see this is the anastomosis, which is nicely placed with the tenia libra on top and the other tissue behind. As this case is a case where the vagina is open, what we did was we cut the omentum of the rim of the transverse colon, and then folded this flap down so that it is covering the anterior face of the bowel, exactly where the anastomosis is, because omentum is immunologically, it's wonderful. It has some extra blood perfusion, and it also allows to seal in case that there would be a small fistula. Now, when there is a large tumor, as you could have seen right now, what we do is we do a complete resection. There might be a little remaining tissue, because the larger this piece is, the more we have to be concerned of not shortening the bowel too much. And this is why we cut this out, and we might leave a little at the rim, so that by doing the purse string suture, this will then move into the the circular stapler. And you can see here we place the anvil, and then have these purse string suture, and thereby fold this inside so that it will finally get into the circular stapler. Now, what I've tried to do is to give you some idea of different ways of how to do it. And it is good if you have this in mind, because sometimes you have to make a decision whilst operating, because also, even though imaging is very important, what you find finally in the abdominal cavity, in the pelvis, might be slightly different, so that you have to react on your situation. Now, the systematic procedure is, once there is a vaginal infiltration, start with circumcision of the vaginal part of the tumor. And in that case, I advise to inject just fluid. Could be NaCl, could be saline, or could also be something else. But it's not important to have a compressive substance, but to just extend the tissue so that you can much easier sort of also dissect the rectum, so that the rectum is mobilized, which makes it much easier to continue the procedure from the laparoscopic part. And this can be done by laparoscopy. Simultaneous hysterectomy, do the hysterectomy first, and then it is much easier to get access to the rectovaginal space, and one can then combine both ways. If only the bowel is affected, one has to have a different armamentarium, and this depends on the size and on the position of the tumor. Now, what might be helpful is to perform a bilateral ovariopexy. We leave the ovariopexy for 2 to 3 days, and then just cut the thread outside, and then the ovaries will fold back into the position. Otherwise, we are also concerned that because of a lot of rough surface in the pelvis, that the ovaries might be attached and that adhesion might form. When the vagina is open, um, um, particularly when the vaginal closure is on top of the bowel anastomosis, it might be helpful to have an omental flap. And as you could see by the presentation of Professor Pereira, ICG can be a good way of testing the perfusion of the anastomosis. Now, the point that is always discussed is a protective ileostoma or not. And I know some groups that always perform an ileostoma. For me, this is not the right way, because we should not forget these are not, as usually with gastric or gastrocolonic surgeons. It is not that we have old patients with a malignancy. We have young, normally healthy patients. They have a good perfusion, so that we are not really forced to have an ileostoma. And in most cases, this works fine. And of course, we also had insufficiency of the anastomosis, but our complication rate is around about 4 point something %, which is low. So we explain this to the patient, and they can decide if they want to have an ileostoma right away, or whether they want us to perform the anastomosis. And just in this rare case that there should be an insufficiency should be developed, then they will get the ileostoma. And this seems to be a good way. Now, one word concerning fertility. As you can see by these points, particularly also by this graph, which shows if first-line surgery has been performed in comparison to first-line AIT, patients benefit with a higher cumulative live birth rate when surgery has been performed first, in case they want to have children and there are not too many other problems. So it is the right way of advising patients to go for bowel surgery, for surgery of deep infiltrating endometriosis first, before going to ART. And I cannot stop advertising that we as endoscopic surgeons, and I know that everybody who has enrolled in the TGMET center has wonderful trainers, as you could see on the panel, and particularly Dr. Pongsak and Ampan as extremely experienced ones. They can allow you to get all the armamentarium to avoid that a mini laparotomy has to be performed. One last word is, please use the Ensign classification. This is right now the only classification that clearly includes the deep endometriosis. And there are different compartments which show this, but also adenomyosis, bladder, the upper intestine, the intrinsic ureter, and distant locations, but also the aspects of the ASRM classification. So there is a classification of the peritoneum, of the ovary, if this is a large endometrioma, and also of the tube, including the patency of the tube. So you have all aspects that you need in this classification. And perhaps either you can download this by using this link, or you can have this code here, depending on how you want to use it. And perhaps you can sort of take this as a basis and have this, we have this in our theater so that everybody immediately knows how this goes. And nicely enough, meanwhile, there's also that ultrasound uses this classification to preoperatively judge the tumor, and also MRI can use this tumor, but mainly, of course, for deep infiltrating endometriosis, because patency of the tube cannot be used. So one can only have specific aspects. So this is the end of my presentation. Thank you very much. It has been a great pleasure for me to join up with you once again, even though it's quite a difference of being online rather than being together with you. And in case anybody should be in Frankfurt, you're most welcome to the Northwest Hospital. Just send me an email and we will arrange for you to come and visit us. Thank you very much.
Thank you very much, Professor.
That's very impressive and such a systematic approach. Just got one simple question. I saw that you kind of rather recommend the ultrasound for evaluating the rectovaginal DIE. Would that be, hello, okay, you're back. Okay. Would you recommend ultrasound over MRI? Or if you recommend ultrasound, would it be transvaginal or transrectal?
No. Well, thank you for this question, Dr. Pataya. The point is, the vaginal ultrasound is easily available in most institutions, even in the outpatient settings. And if one has trained oneself to do the vaginal ultrasound, it is a very good way of detecting bowel endometriosis. However, as you all know, the depth of the ultrasound maximum is 10 centimeters. So if there is suspicion of bowel endometriosis and you cannot detect anything, then as a second line imaging procedure, MRI might really be helpful. And we also had patients that had small bowel endometriosis. I didn't show slides or videos how to operate this because I have used my time anyway. But also sigmoid endometriosis is sometimes very difficult to be detected with the vaginal ultrasound. So you are right. We need to have the full imaging armamentarium, but the bulk of the diseases can be nicely demonstrated using vaginal ultrasound. And it is not necessary to have a rectal probe available because usually people don't have it. It's gastroenterologists that might have it. And I think we need to be proud of ourselves so that we can use our instruments and do not need to have other people around.
Professor, there's a question from Korea. A patient, 48 years old, DIE at rectovaginal septum and rectum 6 centimeter, very low and close to the anus. What is your recommend treatment? To resect the bowel or just leave it with medical treatment?
Well, thank you very much. This is an excellent question. Because of course everybody is afraid of complications and the complication rate is fairly high. I would always resect, especially since it is a big tumor, because a biopsy will never reveal whether there is not only a small part of malignancy inside. And the harder these tumors are to be operated, or the more difficult it is, the more it is important to do it, because what I experienced is that when finally someone does the surgery, there might still be a malignancy inside. So this is something for this Korean colleague I would advise, please be aware of and inform the patient there could be a small malignancy inside this large endometrioma of the low or ultra low rectum. The way to go about is to open the vagina and to dissect the tumor, to mobilize the rectum, and then sometimes if it is so low, you can even use a contour stapler. Once you circumcise or circumdissect the rectum, and then you can use a contour stapler from the vaginal part, particularly if this lady had given birth to at least one child, so that the vagina is slightly wide, then you can introduce the contour stapler from below, from the vaginal part, staple off, and then do the rest from the abdominal part. Was it okay?
Yeah.
It's-
It's okay, but
it's-
maybe complicated for us. And Professor, is you are doing your bowel resection by yourself, or you have the colorectal surgery with you right now?
No, I'm doing it by myself. Well, first of all, the colorectal surgeons, they wanted to participate, but now they say, no, you do it, and that's fine. And this is, meanwhile, I've done so many bowel resections that there's nobody else coming with us. And we sometimes ask if it is high up that we have the experienced colorectal surgeon with us, but never down there. And we also do the ileostoma ourselves. Yeah.
I think I saw one question about transanal approach. I think in your video you showed us the transanal approach for removal of endometriosis, right? I think that there was one video, so I think that answered the question already.
Yeah.
So,
Transanal, I mean, this is a natural orifice to the bowel once it is open. So we introduce instruments through the anus, and we remove tissue also through the anus. And you can also, if it's a huge bulky tissue, we can also put the tissue into a bag and then pull the bag out through the rectum and the anus. If it is possible to keep the vagina intact, we do not open the vagina in order to transport things, either instruments or tissue. We use the anus.
okay, I think time is up. Well, we
Yes.
thank you very much, Professor Tinneberg, for joining us always.
It has been my pleasure, and I'm very happy to see both of you. Okay,
Professor,
Pavel
did you
and,
inject
Mataya.
the COVID
Have you
vaccine?
got vaccine?
Have you got the vaccine yet?
I
COVID-19.
had my first shot of vaccine. Thank you very much for asking. So,
See you next year.
Life can start again.
Bye
All the
bye,
best for
Professor.
you, and stay healthy. Many greetings also
Okay.
to Amman
Thank
and
you very
Kongsak.
much.
Thank you very
Peaceful.
much. I'll see you soon.
Okay.
See you.
Okay, bye-bye.
Bye-bye, bye-bye.